Hi, and welcome everyone. FluGuide recently reported phase 2a top-line data from their trial in head and neck cancer with FG001. And today we have the company's CEO, Morten Albrechtsen, and the company's CSO, Andreas Kjær, to discuss the results. Gentlemen, welcome.
Thank you very much.
Thank you.
And thank you for having us. And we are very excited to share our recent results within head and neck cancer and our optical guidance. So just to take you a little bit back on the product we have and where it started, what we have is really a drug that makes cancer lights up. So it's a drug that you inject into a blood vessel, a vein. Then it seeks out the cancer where it binds, and then it's excreted from the rest of the body. So what you end up with is a cancer that is fluorescent, so you can see it with a special camera. And we took this technology into several different cancer types, and you might recall we previously presented data from brain cancer where it works very well. But this time it's head and neck cancer. And the drug FG001, so this is the drug that binds to the cancer and lights up or is fluorescent, we also tested in head and neck cancer. And one of these head and neck cancers is tongue cancer. And what you see on image number 2 is that we administered this to a mouse that had implanted a human tongue cancer in its tongue. And then what you can see is that the tumor lights up. And where I have my pointer now is actually the tongue that was removed, and it's full of cancer. But we can also appreciate very small green spots here. That's actually lymph nodes that we also dissected. So we could even find the spread of the disease. So in this preclinical model, it seemed very promising. And we also saw that the signal, the target we are binding to, is called uPAR. It's a marker of aggressive cancer, and it's expressed in more than 85% of all solid tumors. So it works across solid cancers. And you can see here the brownish color is immunohistochemistry, so coloring of where our target uPAR is, where we bind to. And that is exactly the location where the cancer is. So we now have a drug that goes to head and neck cancer. It binds to uPAR and makes the cancer light up. So this was so encouraging that we then moved into the clinical setting. And those are the data we are going to present today. And in that clinical trial that included a total of 16 patients, the primary objective was to see if we could detect oral and oropharyngeal cancer. So basically, would the cancer light up just as in the mouse model you just saw? Would it also light these cancers up in patients? And the secondary objective was one thing if it's light up, but we also wanted to assess how intense the signal was, and we measured that as tumor to background ratio. Why are we using tumor to background ratio? Yeah, tumor to background ratio is basically the contrast the surgeons see. So you want the tumor to light up, but you want the surrounding not to light up. And this is a measure that is normally used to see how good this compound works. And then finally, we also wanted to investigate the safety and tolerability of the FG001 in these patients. Of course, in the meantime, we have built quite a large safety database from the previous studies in brain and in lung, so we saw no issues. So we're quite confident that we would not see any issues. But of course, this adds another 16 patients and in a different indication. The trial design was a FluGuide-sponsored study, prospective single-dose escalation clinical trial, and a phase 2 trial. And patients were included with cancers in the mouth or even a little bit deeper of the most common type, squamous cell carcinoma. And it was patients that were scheduled for surgery. And why this? Because we wanted to be a tool for surgery, and also then we got the tumors out and we could see the light in the tumors. and they could not have hepatic or renal insufficiency, just to make sure that there would not be any interaction on the excretion of the drug. Then on day 0, they got FD001 administered, injected, and then the day after, surgery and imaging was performed. And imaging was done during surgery, and we come back to show you the images as the surgeons see them. And then the second part was taking out the tumor specimen, so basically what the surgeon did remove, and also see if it lighted up on the back table. And then finally, one thing is that what we believe is the tumor lights up, but everything was then sent to the pathologist to see on a microscopic level whether it was actually cancer tissue and whether it was actually the cancer tissue that lighted up. And we can already now tell that it was, but we also have some image on that. Then the patients were post-operatively monitored, and then the day after the surgery, they were released when there was no safety issue, and the study was done for that patient. The results, as mentioned, it was a dose escalation study. So we had 4 doses, 4 milligrams, 16 milligram, and 36 milligram, with most patient in 60 milligram. And what we saw was, and you can here see the gender, a good mixture of gender, males and females, a wide range of ages. And we saw, or the surgeons saw actually, a bright signal already from 4 milligram and upwards. Timing between administration of the compound and when surgery was performed was between 11 and 18 hours, so a very flexible window. We saw no drug-related adverse events, so no adverse events that related to our compound, and no serious adverse events. And also, if we look at the adverse events, and remember these were unrelated, it was all in the most of them were in the lighter of the lighter type. To go to the results, this is TBR, so this is the contrast, the tumor to background ratio, and all 16 tumors were visualized. That includes with the low dose. So we had 100% sensitivity for detection cancer. What does this mean? This means that when we move this format as a tool that can help the surgeons, it seems that all patients, or almost all patients at least, will be eligible for undergoing use of FD001 for guiding the surgeon. We also looked at the dose response. Did we gain anything by increasing from 4 milligrams over 16 to 36 milligrams? And as you can see to the right, the tumor to background ratio is around 3, which is a very high number in this space. Normally, rule of thumb says above 1.5, then it works well. So we had a high contrast of 3. It was actually the same for all 3 doses. And this tells us that we can go pretty low, 4 milligram in these patients, and we get a good signal, and we gain nothing more than increasing the doses. And this is, of course, very nice. It decreases even more the risk of any side effects. And of course, it also uses less of the compound. And then to the more exciting stuff, how did it look for the surgeon? And this is an example of a patient with a tumor in the tongue. You can see it here on the normal image. It sits here. And this is FD001 lightening up. We now turned on the near-infrared vision. This is in the near-infrared field. You need a laser. You cannot see it with the naked eye. And then you can put that image of FD001 on top of what you see in white light. And this is what is done here, superimposed. So all the yellow, orange, bluish coloring here is the tumor. So very, very nice guidance for the surgeon. Where does the tumor sit? If we then, this was in vivo, so this was while the patient was ready for surgery. And what is seen here is the ex vivo imaging. So as I mentioned, once the surgery was done, the surgical specimen was also looked upon with this technology. And here you can see this is just when the tumor was removed. It lights up because FG001 sits there. And this can be used actually to see, did we obtain a negative margin all the way around the tumor? So does the light end before the specimen? Also, formalin-fixed tissue still lights up. So even if you prepare these samples, preserve them, you still have the optical signal. On the microscopic level, this is a tumor, UPAR here, the brownish is the tumor. We outlined the tumor here with a yellow line, and you can see that is exactly what lights up with FG001. So a precise fingerprint of where the cancer sits, and this is the reason why we can use it for margin delineation. We can see, did we obtain what is called negative margins? So did we cut outside of where the tumor ends? This is now a video. This is the tumor. You can see lightening up in the middle here. And when I start the video, you can see the surgeon manipulate this tumor and how it actually continues to light up. And this tumor is actually a metastasis. So it's not the primary tumor. It was something that was spread to lymph nodes, a metastasis, and which you could easily detect by this technology, and you can easily see where it is. And when you remove it, you can see that no light is left behind. So very, very elegant technology. And of course, the surgeons were as excited as we are. Just some more samples here where you can see another sample. It's difficult to see how large or big is this tumor. It's the teeth you see here because it is in the mouth, the tongue. And here you can see when you do the overlay, it's probably larger than you appreciate in the beginning. It's actually more out here that the rim of the tumor is. And this is exactly what the overlay is meant for. And here's another checking with near overlay in the cavity. This is the tumor being removed. And when I start the video here, you can see how where the tumor sits, it lights up on the bottom of this piece of tissue that is taken down. Again, easy to see where is the tumor, easy to delineate, and easy to make sure that you have removed all of the tumor. So very exciting, and to the right, just another example. Here are some more examples of both in vivo, how it looks while the surgeon is operating. Here again, you see the teeth here, and this is in the oral cavity. And also once the tumor is removed, as you see on this piece, you can see it still lights up. So it doesn't stop lightening up just because you have taken it out, which makes it very good for pathological evaluation. So we believe FG001 is a very promising intraoperative decision tool for margin assessment. And what is margin assessment really? I mentioned it briefly, but it's well known that if you remove all of a cancer, and what does that mean? You have not left behind any cancer in the margin, you have clean margins, then the prognosis is much better than if you leave anything behind. So this is how this tool can be used. And without going into too much details, for head and neck cancer, there's even a correlation between how much negative margin you have and what your prognosis will be. So you should not only remove the cancer, but you should also make sure that you have a rim of, for example, 5 millimeters of healthy tissue as a safety margin. Then your outcome is better. And this is exactly what this tool can be used for. So there's a lot of possibilities here where we can expand it, not only for making sure you remove in the best way the tumor, and of course, needless to say, if you on the specimen see that you did leave some tumor behind, then the surgeon, without having to call in the patient a second time in the same session, the surgeon can go in and clean up what was not seen in the first instance, what was left behind, and thereby improving the prognosis of the patient. But it doesn't stop here. We can even use it for detection of cancer on unknown primary. What is that? That is very often a lymph node metastasis, just as the one we showed you previously that lights up is found, but it's a metastasis, but it's not known where the primary tumor sits. Where does this metastasis come from? It's known that it's in the head and neck region, and there this technology, our technology, can actually be used to detect where there might be any cancer tissue. So for this dissection, it's really good. It can also be used for seeing where on the neck there might be metastasis. If you have a very large tumor, the likelihood that you have metastasis is also high, and then you have to find out where is it. You cannot take out, or it's impractical to take out all lymph nodes and check them pathologically, but we want to see whether we can guide the surgeon and say, if they are not lightening up, or if they are lightening up, then it tells that there's no metastasis or are metastasis. And then finally, it can also be used together with robotic surgery, because all these robotic systems, and that's in particular far back in your oral cavity, you do these operations. All these cameras come with optical capabilities, so they can, just as you saw in orange, the overlay, they can overlay for the surgeon while they are using this robotic robot for surgery. So very exciting, and a thing that we will pursue in the future. So to conclude, this study in head and neck cancer with FG001 allowed for real-time intraoperative optical visualization of both tumor and metastasis in oral and oropharyngeal cancer. The signal intensity was good. We have written acceptable. I would say it was good. It was free, so twice as much as normally is considered okay. And it was the same as at low and high doses, which point to a low dose of 4 milligrams. The study confirmed, in line with our earlier results, that the compound is safe and well tolerated. And in future studies, we will explore the clinical benefits in surgical management of head and neck cancer patients. We mentioned the negative margin, that is the obvious indications, but we will explore additional indication and believe that it will be of value to the surgeons, and of course, what is ultimately the goal for FluoGuide, be of value to the cancer patients, so they can survive longer and have a better quality of life. Yeah, so that was our data. We are excited, so I hope the listeners and the viewers share our excitement.
Certainly. Thank you so much for that great presentation. I just have a couple of follow-up questions there. Now, you already mentioned that you saw similar tumor to background ratio with 4, 60, and 36 milligrams. Can you just elaborate a little bit on why it is best then to take 4 for continued studies?
Yeah, for obvious reasons, we don't want to give, I mean, even though it's very safe, we want to give as little. That's a general principle with drugs, even it's not an active drug, but just a marker. So we want to go as low as possible. So that's basically a safety issue. What happened is the signal might be a little bit higher, but what you're going for is the contrast. So if you just add to a stronger signal on the tumor, but the background rises in parallel, you don't really gain anything. And our light intensity is extremely high. The systems we use to visualize these things actually have to go very, very low in their gain, not to overshoot. So there's a 100-fold margin on that we can pick up the signal. So that's the reason we want to go as low as possible. And at least here, we didn't see any disadvantages of going for 4 milligrams. So that would be the reason.
If I can add to it as well, I mean, it is also underlying the flexibility of our product that is very robust across different doses. So it also robust across different kind of equipment that we can use a range of different equipment, and we're not limited by toxicity. We actually have a very broad window where it works well. I think it's kind of the take-home message from this.
Got it. And then when it comes to continued clinical studies, can you already say whether you, for example, will do a phase 2b and then a phase 3 study, or potentially combine those two, or is it too early to tell?
Yeah,
I think it's too early to say. I think, I mean, as you also mentioned from the beginning here, we would like to see the brain cancer trial coming out here later in the month. We would like to dive a bit deeper into it. We would like to integrate the regulatory feedback, equipment feedback, and also some of the key opinion leaders' feedback. So this presentation was just presented in a congress in Korea here in last week. That's where they come from. And there's a lot of important feedback from investigators around the world where we would like to take it into consideration. So if you bear with us, we would like to come out with give this piece of information as soon as we get it, but we take all the things into consideration when we announce it. But the good thing is that we can move quickly from here. That's one point that is important. The other point is that we want to do it on predictable, and it's not important to start early, but to get early to the goal, and then of course to the patients.
And I think also maybe more we can say, I think we have the luxury of having a signal here that is extremely robust, and as mentioned, 100% lighted up. So it's not like we have to optimize to get the signal. So from here on, it's basically positioning in the best possible way. There's a lot of flexibility. Also, you could see there was also a broad range, a window time-wise. So it doesn't need to be injected at a very, very specific time point. That was also a range we covered. So basically, it's the day before you can give it, and then it doesn't matter when you undergo surgery. So I think we have something extremely robust that gives us a lot of room for maneuvering and positioning in the best possible way. So we are very excited about that.
I agree.
Certainly sounds very exciting. Also, when it comes to head and neck cancer, in this trial you focused on specific subforms of the disease. Can we expect later stage trials to be in general head and neck cancer, or do you still plan to focus on specific subgroups in that population?
Yeah, I think it's only partly right, because it was actually a mixture of oral cancer and oropharyngeal cancer. They weren't tongue cancer, all of them. They were somewhat overrepresented. But it's also, they were also represented because it is a very common type. So I think so far it's oral and oropharyngeal we are covering with this study, and we can generalize it for those. And it's also the things we are discussing. Should we go into larynx and even more extensive on head and neck cancer? They do share common traits. They are what is called squamous cell carcinomas, so they behave very much in the same way, but of course surgically and when they are discovered and so on, they do differ, but that's some of the considerations. But I would say with this study we have covered both oral and oropharyngeal, and it's not only a tongue cancer study, even though they were represented as the largest group.
Perfect. Very interesting. Now, that wraps up all my questions. Morten and Andreas, thank you so much for doing this interview, and we look forward to hearing more from you once you release your phase 2b results in high-grade glioma.
Thank you, and thank you for having us.